recorded.
You can start now.
Hi, a very good evening to all. Welcome to the CME Importance of Salt and Sugar in Nephrology by Indian Medical Association along with Asian Kidney Hospital and Medical Center. I am Dr. Rahul Chaube. I am your MOC and I will guide you through the whole program today. We are joined today by the President of IMA branch Nagpur, Dr. Sanjay Devtale sir, the Honorary Secretary of IMA Nagpur branch, Dr. Sachin Gathe sir, and our convener, Dr. Shehnaz Chimthanwala ma'am. I welcome you all to the CME. We are also here with Dr. Ashish Desawal sir, who is the MMC observer for the day. Sir, you are, it's an honor to have you on our CME today, sir. I request Piyush to flash the e-memento for Ashish sir. So we are very honored to have you on the CME today, sir. Without further ado, I request Dr. Sanjay Devtale sir to take over the virtual mic for a welcome address.
Thank you, Rahul sir. Good evening, respected dignitaries, speakers, chairpersons, convener, moderator, and MOC. Importance of sugar and salt in nephrology. The important CME in association with Asian Kidney Hospital and Medical Center. We dedicate this CME to our beloved teacher, Dr. B.S. Chaube sir, who was pioneer in nephrology in Central India when we are having very limited resources, particularly of investigations. Congratulations to convener Shehnaz madam and MOC Rahul Chaube sir for coordinating whole CME. And we are already having 300 participants on the board. This CME will add more sugar to our knowledge. I thank Ashish Desawal sir, MMC Observer, for joining this CME. Jai Hind, Jai IMA. I further hand over the mic to Rahul sir for that.
Thank you so much, sir, for your warm welcome. Surely, we are now having 322 attendees apart from the panelists. I'd like now to hand over the virtual mic to Dr. Sachin Gathe sir for a vote of thanks. So, sir.
Thank you, Rahul. So today's CME, sugar and salt. In context of the health of kidney, I would, on behalf of IMA Nagpur, I would like to thank to our speakers, Dr. Atul Ingle, well-known nephrologist, who is going to speak on detection of diabetic nephropathy at earliest, how to follow it, how to prevent it. Then our second esteemed speaker, Dr. Mukesh Shetty sir, is also a well-known nephrologist. He's going to speak on salt and hypertension through a new is going to speak on various newer aspects on this topic. For both the session, we have speaker and the chairperson, Dr. Manish Balwani and Dr. Amit Pasari, both well-known nephrologists. I would like to thank accepting as a chairperson. And I also like to thank to our convener, Dr. Shehnaz Chimthanwala, Vice President, IMA Nagpur, for conveying this CME right from applying for the MMC credit point and other things. Thank you, Shehnaz madam. I would like to thank to moderator, Dr. Samir Chaube sir, a well-known nephrologist, for planning this CME and executing these CMEs with in association with IMA Nagpur, and MOC Dr. Rahul Chaube. Thank you very much. Also, I would like to thank our digital partner, DigiShield, Deepak and Piyush for conducting this CME on the digital platform. And last but not the least, our delegates. They are joining in large number. Hopefully, we will have more than 500 delegates. Already more than 350 are joined. So, not taking much time, I thank you all, and I hand over the virtual mic to our today's young, charming MOC, Dr. Rahul Chaubey. Thank you.
Thank you so much, sir, for your kind words. Now we go to the introduction of the CME. Today we are joined by some of the finest nephrologists in the country, Dr. Atul Ingle sir and Dr. Mukesh Shetty sir, who are our speakers for this evening, and Dr. Sameer Chaubey sir as our moderator. We have two major updates in the Department of Nephrology, Diabetes and Hypertension, two out of many culprits of an end-stage renal disease. Our chairpersons for this evening are two of the well-known nephrologists in the city. The first chairperson is Dr. Manish Balwani sir. Dr. Manish Balwani sir was awarded DM degree by the Gujarat University for Nephrology, and he received fellowship of American Society of Nephrology for his academic excellence. He has received various awards for his major contributions in the field of nephrology and transplantation, including TTS ISO-DP Young Scientist Award 2015, TTS International Mentor-Mentee Award 2018, ISN 2015 West Zone BN Khurshedji Award, and ISOT and Asian Society of Transplantation, K. N. Uduppa Memorial Oration, New Delhi, October 2019. He is the founding member of Kidney Transplant Program, which has started at the Government Medical College and Super Specialty Hospital, Nagpur. He has published over 47 papers in national and international peer-reviewed journals, and he has made oral presentations at various national and international conferences such as ISHD, TTS, ISO-DP, and ISN. Under the mentorship of Professor H.L. Trivedi sir, his research revolves around preventive nephrology and renal transplantation. It is an honor to have you on board, sir. Welcome to the CME, sir. Our second chairperson today is...
Thank you for warm introduction.
Our second chairperson is Dr. Amit Pasari, sir, with 4 gold medals in MBBS and top of his batch in DM nephrology. Dr. Amit Pasari, sir, is a consultant nephrologist and director of Saraswati Kidney Care Center, Nagpur, India. After completing his DM nephrology from IPG MER Kolkata in 2014, he secured his SCE from MRCP UK in 2018, and he has 15 publications to his name. He has a special interest in permcath, percutaneous, CAPD, and jugular catheterizations. It is an honor to have you today at the CME, sir. I now hand over the virtual mic to our chairperson, Dr. Manish Balwani, sir, for further proceedings.
Thank you, Rahul, for that warm introduction. It's my honor to introduce Dr. Atul Ingle, sir. He is director at Nephrology Department at Fortis Hospitals, Mumbai, and he is honorary professor of medicine, University of Mumbai. He has been awarded for innovation and excellence at international conferences. He has been panelist for American Society of Hypertension, also has been panelist for KDOQI Guidelines for Management of CKD and Diabetic Kidney Disease by NKF in USA. He has received many awards to his credit. To name a few: Vikas Ratna Shiromani Award, Indian Gold Achiever Award, Health Icon Award, Abdul Kalam Excellence Award, Times Galaxy Shining Nephrostar Award by Times of India in 2021. He is member of many national and international societies of nephrology and transplantation. He has been invited as a guest speaker at national and international conferences. There are so many, I cannot name each and every one. I am very impressed at looking his CV about extracurricular activities. He has passed all professional drawing exams. He is a junior national champion for badminton from 1980 to 1982. He has been winner at badminton championship at All India Intermediate level. He has represented university in badminton and cricket. He is second runner-up in the Himalayan car rally in 1996. He was winner of the car drag race in Mumbai in 2001 and 2002. It's all my honor to introduce such a vibrant personality, and I would request Dr. Atul Ingre sir to deliver his talk on detection of diabetic nephropathy at the earliest, how to follow it, and how to prevent it.
Good evening, friends.
Good evening, sir.
Thank you so much for those kind words. Rahul, can I have control over the screen?
Yes, sir. So just share screen.
Yeah, I'm going for it. My slides are visible? Slides are visible?
Yes, sir. Now it's visible.
Okay. So let me start formally. Good evening, respected chair, my elder brother Samir, Manish and Amit, and my dear friends. First of all, I would like to thank IMA Nagpur from bottom of my heart for two reasons. Number one, Nagpur and Nagpur IMA is always very close to my heart, and I never miss a chance to drop down at Nagpur because of Samir, and my ancestral belong to Nagpur region. The second most important reason is almost after gap of 11 years or 12 years. Samir and Mukesh, please correct me. Slides are not forwarding. After almost a gap of 11 to 12 years, Samir, me and Mukesh are coming on the dais for the CME purpose. Of course, we meet every now and then, but for CME purpose, delivering talk or conducting session, this is almost a gap of 10 to 11 years. And the fond memories of the Tashkent CME, which was held in 2011, September, I think 16th and 17th. My dear elder brother Samir and my nephew Rahul requested me to speak on diabetic nephropathy. How to detect diabetic nephropathy at the earliest, how to follow it up, and how to prevent it. And they have allocated with a great empathy 20-25 minutes for such a small topic. I started wondering whether I am competing with this gentleman. He's a British person by name Steve Woodmore, who clocked almost 637 words per minute. And to cover this topic, I think I will have to chase him, or maybe faster than him. I will try my level best to make it crispy and to the point. This graph is a kind of owner's pride and neighbor's envy for any sales or marketing person, because this graph is going up and up. But if you look at it carefully, it indicates or denotes the figure as per the time. And these figures indicates diabetics in the world. To present it, there are almost 537 million diabetics in the world, which are expected to be somewhere around 786 by the end of 2045. What about India? There are almost 95 million diabetics are there in today's date. Or if you take randomly 10 people, one would have type 2 diabetes. The diabetes has become rampant. Few years back, India was a capital of diabetes, but now, as usual, China has taken over. So China is number one, India is number two. What is the difference between us Indian diabetics and the Western counterparts? It's a relatively earlier type 2 diabetes onset, higher insulin resistance, and greater insulin secretory defect. If you look at the mortality which is related to diabetes, let's compare IDF data of 2017 and 2021. There was one death per 7 seconds in 2017, which is related to diabetes. Now it is one death per 5 seconds. death which is related to diabetes, which equals to almost 6.7 million deaths annually. If you look at the common complications related to type 2 diabetics, and let's compare diabetics with the non-diabetic person or a normal individual, and you can see chronic kidney disease is at number 1 spot. So CKD is a very, very common complication of diabetes or type 2 diabetes. As you are all aware, diabetes complications can be broadly classified into microvascular and macrovascular complications. Diabetic nephropathy falls into the category of microvascular type of complication. 2007, K. Docky and K. Digo re-christened diabetic nephropathy as a diabetic kidney disease. So diabetic kidney disease and diabetic nephropathy are synonymous. If you look at the nephro data, type 2 diabetes is number 1 killer in nephrology. That means it is a number 1 cause of CKD or end-stage renal disease. Number 2, of course, stands hypertension. So much so that if you randomly select 3 type 2 diabetic patients, one would have definitely diabetic nephropathy or diabetic kidney disease. It is so common. It is so common. Let's come to the Indian statistics related to diabetic nephropathy. If you look at this graph, most of the cases are detected stage 3 onwards. The maximum cases means 40% cases are detected in stage 5, stage 4, 30%, stage 3, 23%. And that is a apathy of diagnosing diabetic nephropathy, which is need of an hour. That is the reason one should go for detection of diabetic nephropathy at the earliest. I am going to take 10 seconds of you over here. You have to concentrate on this figure, the green dot on the nose of this beautiful lady. And once you concentrate for 10 seconds, just look into this white background. What you can see is a face of beautiful female. This is a kind of a negative, black and white, and this is an actual picture. This is what is known as visual or optical illusion. The point where I would like to draw your attention is that you need to detect diabetic nephropathy. Patient is never going to come to you with the symptoms, or you are not going to find out any signs unless and until it is a very advanced stage. There are no complaints as such if patient is in stage 2 or 3 of diabetic nephropathy. So you need to detect, you need to go for screening. But screening is a daunting task. If you take a simple figure, 95 million diabetics in India, if you start screening them, there would be somewhere around 26,000 screenings per day or 18 screenings fall per minute, which is practically impossible. So what are the clues or when one should screen? You should look into the predisposing factors. If patient is giving history of genetic predisposition, that is in the form of history of hypertension or cardiovascular event in the first degree relative. If patient is having evidence of hypertension, dyslipidemia, then you should look for a screening. Most importantly, ask for a diet. If patient is consuming a lot of non-veg diet, that is non-vegetarian, you should go for screening of the diabetic nephropathy. Or worst is a tobacco. In India, more than a smoking, tobacco chewing, gutka, tobacco, and so on. That is a worst addiction factor and a worst factor for a progression of diabetic nephropathy. Not even diabetic nephropathy, even chronic kidney disease. This is a worst factor what Indian can face. So when one should screen diabetic patient for diabetic nephropathy, if patient is having type 1 diabetes, then initial screening should be 5 years after the diagnosis. But consider it after 1 year only if there is a poor metabolic control or patient has attained puberty. About type 2 diabetic, you should screen them at the time of diagnosis. Now, why I'm saying or why guideline is saying that type 2 diabetics should be screened at the time of diagnosis? There's a beautiful study which was published in 2010, that is Journal of American Society of Nephrology, where non-diabetic patient having proteinuria were biopsied, and biopsy they found to have isolated glomerular basement membrane thickening. So these patients were tested for diabetes. Out of that, 20% were positive at the time of biopsy, 34% were diagnosed to have diabetes after 6 months, and 46% were positive after 2 years. That indicates that diabetic kidney injury starts pretty early before you diagnose type 2 diabetes, maybe in metabolic syndrome itself. Later on in 2013, meta-analysis has shown that the incidence of diabetic nephropathy is almost 60% on the day when you diagnose type 2 diabetes. So the screening of diabetic nephropathy and type 2 diabetes should be on the day 1 itself. Now, what you will screen? How you will screen diabetic nephropathy? You should go for albumin urea. Ideal one is a measurement of albumin excretion rate, but this is a cumbersome process because you need, or patient need to collect 24 hours urine, and many fallacies are there. So many times you get wrong report. The best and the most ideal and the most practical is urinary albumin to creatinine ratio, that is ACR, in the spot urine sampled any time of the day, which should be expressed in milligram per gram. Secondly, you should go for estimation of GFR, that is known as eGFR, with the help of serum creatinine. How? That I'm going to show you later on. If you look at the geometric presentation of the glomerulus, these are normal glomerulus and these are diabetic patients' glomerulus, and you can see there is a reduced number of podocytes. There is a flattening of the foot processes over here. There is an increase in mesangial cells, and there is a flattening or expansion of endothelial cells. All these factors lead to protein loss or albumin urea. And believe me, this is the time which indicates paucity of insulin or insulin resistance has gone to the worst. So let's come to the albumin urea. I will speak only about the albumin creatinine ratio, which is expressed in milligram per gram. If it is less than 30, previously it was termed as normal albumin urea, but now it is termed as normal to mildly increased albumin urea, or as per KDIGO, it is termed as A1. If albumin urea ACR is 30 to 300, previously it was known as microalbumin urea, but now, or in between, it is known as moderately increased albumin urea and denoted with A2. Last one is more than 300, the ratio, which was termed as a severe or macroalbumin urea. Now it is termed as a severely increased albumin urea or denoted by A3. What is the significance of this denotation? I will explain you with the help of example. So once you start screening, test for albumin urea. If test is negative for albumin urea, you should screen that person for albumin urea again after 1 year. But if the test is positive for albumin, you should confirm or rule out invalidate report. Now, which are the conditions which can disturb or give false positive type of albumin urea? One is the posture, vigorous exercise, hematuria, infection, fever, or transient hyperglycemia. So treat this condition and then repeat the test. If that test is negative, then go for a repeat test after the gap of 3 to 6 months. Means you'll have to repeat twice. If that test is positive, then you treat this condition and repeat the test. And if it turns out to be negative, then you can rescreen them after 1 year. So once you screen the patient 3 times, first in the beginning, then later 2 at the gap of 3 to 6 months, and 2 out of 3 tests are positive, then you have to label that person or patient as having albumin urea and start treating it. Second criteria is a eGFR. The GFR cutoff limit given is a 60, which should be persistent for more than 3 months. But you have to go for a modified criteria given by KDIGO, where you have to take into account about the damage to the kidney in the form of radiological or biochemical test that everyone knows about that. So what you are calculating is a eGFR or estimated GFR. Cockcroft and Gault is a time-tested formula, but this formula doesn't take into account body surface area. So this becomes invalid. The MDRD formula gives a lesser amount of GFR for Asian population. So this is no more used. What is used is a CKD API equation. The ready-made calculators are available online. You have to just feed in parameters like creatinine, then age, the gender, and the ethnicity, and you get the GFR that is known as eGFR. We should be proud because this CKD API formula has been founded by Dr. Ajay Singh, Indian-born nephrologist. There are 5 stages of diabetic nephropathy: hyperfiltration, salient, incipient, overt, and end-stage kidney failure. Of course, these stages has been documented in type 1 diabetes, so doesn't hold any value in type 2 diabetes. Recently in 2014, Japanese group of doctors came out with one more classification, and this was published in 2014 Japanese journal. The problem with this classification is that their cutoff limit of GFR was 30, which is too low. So nobody is using this classification anymore. So let's stick to the algorithm given by KDIGO in 2012, how to diagnose CKD or how to diagnose diabetic nephropathy. Let's take an example of Mr. Rex, who is a 58-year-old male weighing 90 kg, he is smoker and diagnosed to a hypertension. He is already on 3 types of antihypertensives. He presented to the clinic with the breathlessness and edema. On examination, his pulse rate was 94, BP was 160 over 98. Edema was there. Rest of the systemic exam was unremarkable. On the routine lab investigation, his RBS was 140, creatinine was 1.4, urine was within normal limit, lipids, uric acid normal, 2D echo, LVH, other parameters were quite okay. So looking at these reports, you will just jump to the conclusion that he requires a modification of antihypertensive and treating. No, you should have suspicion in the mind. This gentleman is 58-year-old, overweight and smoker, already diagnosed to have hypertension. So on further investigation, simple, because take example of creatine. Creatine 1.4 apparently looks upper limit of normal. That is not the case. You should go for eGFR, and his eGFR turned out to be 55. Just simply calculate 58-year-old male, Indian origin, and creatine of 1.4, and you will get a GFR of 55. So that is eGFR 55. Urine albumin upon creatinine, ACR, is 400 milligram per gram. Urine routine was normal. Ultrasound did show left side kidney slightly smaller, and to utter surprise, HbA1c was 7.9%. So he is diabetic. If you fit in the algorithm given by KDIGO, you can see as per the GFR, he is in stage 3. And stage 3 has been subdivided into 2 categories, A and B. So he is in stage 3A. So how it will be denoted? CKD G3A. G stands for GFR. 3A is a stage. At the same time, he is having ACR of 400, which is A3, denoted by A3 over here. So diagnosis would be CKD G3A A3. So that should be the ideal diagnosis. Now, what is the utility of this algorithm? Let's put this person in the color code algorithm of the KDIGO. So he stands a very high risk of progression of CKD to end-stage renal disease, where he stands over here. What about cardiovascular disease? Yes, again, a very high risk of developing cardiovascular complications. So that is the reason you should carefully check or examine patient and scrutinize and screen, because I'm sure after looking at these parameters now, your mindset will change and your treatment is going to be very aggressive, very careful. So coming back to our topic, just to give you a hint about albumin urea and the GFR, There was a study published by Italians in Italian journal, and that study is known as RIA study, where they have examined 15,000 patients of type 2 diabetics. And what they found, elevated albumin urea displayed typical more of microvascular complication. And whenever albumin urea is less, with the impaired renal function, means fall in the GFR is more, then they had more of a cardiovascular or macrovascular type of complications. This is just to show you one of my patient whose albumin urea is near normal, 35, but GFR is 35 because creatinine is 1.6 and the age is 53. She is a female. So naturally, she is at a very high risk of progression. So just don't jump into one criteria, whether albumin urea or GFR. You have to take into account both the factors together. How to follow it up? Well, if person is negative for diabetic nephropathy, you have to rescreen them after the gap of 1 year or 12 months. But nowadays, we are repeating the screening test just at the end of 6 months. If patient is positive and poor control, then every 3 months patient should be continuously screened and checked. If there is a good control, then you can extend it to gap of 6 months. The parameters to check is ACR and the eGFR. How to prevent it? If you look at this great trial, Kumamoto trial, the first graph shows the earlier detection and the second graph shows intensive management. Both the graph is showing the difference that if you detect early diabetic nephropathy and if you treat diabetic nephropathy aggressively, you can slow down the progression of diabetic nephropathy to end-stage renal disease. And this is a KDIGO. Their fundas are very, very clear. If your GFR falls below 25% of normal, you can literally stamp out the date of renal replacement therapy or the transplant, because average fall of GFR in diabetic nephropathy or CKD is 4 to 6 ml per annum. So this is how person progress from stage 1 to stage 5. And the left side graph, what it shows, if you look at this gray area, this indicates the patient was intervened at a very early stage. Means earlier detection, earlier intervention, you can virtually or literally increase the life of the kidney by 3 to 4 years. Means you can postpone the date of dialysis. These are the risk factors one should take into account while treating diabetic nephropathy. I'm not going to go into details. I'm going to stick of one point, that is hyperglycemia. The king of landmark trials, UKPDS, because still we take reference from UKPDS even after 22 years. This data was published in 1998. And what they are clearly shown, if you go for a proper management of hyperglycemia, you can reduce microvascular complication by 25%. It's very, very simple. Their fundas were very clear. Let's take a look at the advanced trial. They have shown if you manage glucose intensively, means intensive glucose lowering therapy can reduce the risk of progression to ESRD by 65%. Can you believe? By simply controlling sugar properly, you can literally reduce the risk of progression of diabetic nephropathy. So what is the culprit? What factor we should target or what we should look at it? It is chronic hyperglycemia. This is hypoglycemia, this is euglycemia, and this is a hyperglycemia. So chronic is an important term. Chronic hyperglycemia is the culprit or the killer in any of the micro or macrovascular complications. So today we'll stick to microvascular complication, that is diabetic nephropathy. So chronic hyperglycemia is a killer in diabetic nephropathy. So what is the standard indicator of chronic hyperglycemia? Is HbA1c. HbA1c gives you fair idea about the glycemic control, because if you look at the people who believes in fasting and postprandial sugars, HbA1c gives a good idea. If you believe in if treating doctors or people believe in advanced trials, like advanced investigative tools like a MAGE, mean amplitude of glycemic excursion, or a mean blood glucose. Again, HbA1c is an average standard. So HbA1c is taken as a gold standard for a glycemic control. What happens in diabetic nephropathy? Well, HbA1c is very good till stage 4. Stage 5, it is highly unreliable because of blood transfusions, erythropoietin injections, or fluctuating in the sugar. Fructosamine, which is one more investigative tool, is not better than A1C, which gives idea about 3 to 4 weeks, while A1C gives idea of 2 to 3 months. Glycated albumin, which gives idea about 7 to 14 days, but this should be used only in stage 5, that is the patients who are on dialysis. So this would be a better marker for glycemia. The meta-analysis, which was published in 2011, has shown a U-shaped relationship of A1C control, tight control or no control at all, because A1C level less than 6.5 or more than 8 was strongly and independently associated with risk of progression to ESRD and increase in mortality. What our guideline says, stick to 7, magic figure of 7. So if you keep HbA1c to 7, is meant for prevention or delaying progression of diabetic nephropathy. Not targeting below 7% if patient is having risk of hypoglycemia, or to be extended above 7% with the comorbidities or limited life expectancy. Everything changed in 2012-13. This was a poster published in American Society of Nephrology. What they did, they studied 80 cases of chronic kidney disease whose average A1C was 7.1. As per the guideline, very good control. But there was an incidence of hypoglycemia to the tune of 76%. A1C failed to portray the excursion. And this was a trigger point about the terminology which I'm going to discuss in next few slides. So these excursions or ups and downs of the sugar level is known as glycemic variability. Just to explain you properly, these both the patients whose A1C is 8, but look at the sugar graph. In patient number 1, there are a lot of ups and downs, while in patient number 2, there are no many ups and downs. So this is known as a glycemic variability. And this patient number 2 is having low glycemic variability, while this patient number 1 has got a high glycemic variability. If you look at the clinical definition, glycemic variability takes into account intraday glycemic excursions in the form of hyper or hypoglycemia. It also takes into account postprandial excretion. The hypothesis is that these excursions are because of diminished or absent glycemic autoregulation or shortfalls of insulin availability. The experimental animal studies have shown that intermittent high blood glucose exposure rather than constant high blood glucose exposure has shown to be having deleterious effect. Means excursions of the sugar level higher side are bad. If patient is exposed to the continuous higher level of sugar, they are sometimes better. The DCCT trial, which was a very famous trial, one of the participants, Dr. David Nathan, found out that patients whose A1C was well controlled had a hypoglycemic complication. So he was wondering what is the problem. And then he derived terminology known as A1C derived average glucose. He calculated this average glucose with the help of this complicated formula. And this is later on known as glycemic variability. There are many more formulas to calculate glycemic variability. I never understood this, but this has been now used by many of the readily available instruments, for example, continuous glucose monitoring instruments and all that. How to read that, I'm just going to show you very quickly. So what is the significance of this glycemic variability was studied in 2013. The study was aimed to determine association between GV and length of hospital stay plus 90-day mortality. And what they found, significant association between high glycemic variability and longer length of stay and increased 90-day mortality. The association was not significantly influenced by age, race, service of care, HbA1c, BMI, or use of regular insulin in the hospital setup. At the same time, association was noted to be independent of glycemic control and hypoglycemia. And the reason for this glycemic variability is a overproduction of ROS, that is reactive oxygen species. So later on, everyone started studying glycemic variability, and the high glycemic variability is closely associated with the worst outcomes. For example, severe hypoglycemia or major adverse cardiovascular events or even all-cause mortality. The gray color bar are showing the highest numbers, which is statistically significant, and the gray color bar indicates high glycemic variability. What is the solution for this glycemic variability? There's something like time in range, means amount of time spent in that particular range of the glucose level. The range given is 70 to 180 milligram per deciliter. So amount of time spent in that range is known as TIR. The time spent below that, means below 70, is known as TBR, and time spent above 180 is known as TAR. If you look at this continuous glucose monitoring example, 74% figure indicates the time spent, maximum time in a day, 24 hours, is spent in the range of 70 to 180. The red color indicates the time spent below 70, and the yellow color indicates time spent above 180. You look at this, if time in range is 50% at least, means this figure is 50%, person's A1C should be around 7%. The international consensus has given the ranges for different class of people. For any type 1 or type 2 diabetic, what they say, time in range is 16 hours 48 minutes, that is 70 to 180 level. Person can spend less than 4%, that is less than 1 hour in the range below 70. Person can spend 6 hours above the range, above 180, that is 25%. We will not discuss this particular point. But if older individual or high risk individual, this has been fluctuated. So TAR is more, that is 50%, and TIR is reduced to 50%. So this is better for patient with a comorbid condition or an older individual. If you look at the relationship of TIR and the macrovascular complication, each 10% less TIR, retinopathy progress increased by 64% or nephropathy by 40%. So it is directly proportional to the microvascular complications. I'm not going to go into details of this particular table, but you can manage patient in TIR of 58 to 70% because the maximum benefit derives are over here. There is no point in going above that. It means like 80% in TIR and all that, that is practically impossible. How to target this patient? So whether it's a routine patient or whether we older individual or a complicated patient, first you should concentrate on TBR. That is time below range. Means if person is getting too many hypoglycemic episodes or average sugar is remaining more than 20% of time, then you should first target that and adjust the medication. Then later on you concentrate on TIR, and for the older or complicated individual, then you should concentrate on time above the range. Last few slides, how Indian diet disrupts TIR. As you are well versed or well aware that energy source of Indian diet is almost 70 to 75% of carbohydrates. So if we consume high carbohydrate diet, there is a glucose spike followed by insulin spike, which is causing hypoglycemia, and this induces hunger again. Many of our patients, they see we take the medicine and we feel hungry, so we start taking take some food or some munching. So this is the big problem with the Indian diet. You need to modify the timing or Indian diet at the same time if you really want to control patient in TIR. Before I finish off my talk, something new. The DAPA-CKD trial has shown that dapagliflozin prolongs survival irrespective of baseline patient characteristic. These benefits were driven largely by reduction in non-cardiovascular death. So death related to diabetic nephropathy also included in this. So this molecule is quite widely discussed in cardiology and nephrology also. Secondly, if you want to check on progression of diabetic nephropathy, you can use cardiac markers like NT-proBNP or plasma CXCL12 or urinary NGAL. This will give you a fair amount of idea. It's something like checking prostate specific antigen. You have to keep on checking serially and you can assess the patient whether he is progressing, whether he is halted or slightly improved. Lastly, good news for us, vadadustat is a hypoxia inducible factor, is a treatment for anemia of CKD. The most important thing is it's an oral form. So no more weekly injections of erythropoietin. You can use this hypoxia inducible factor. Thank you so much for the patient listening. So over to you, Samir, as a moderator.
Thanks, Atul. Lovely presentation as always.
Thank you so much.
Rahul.
Thank you, sir, for the excellent presentation.
Thank you so much.
Sir, one thing that I wanted to ask was, albumin estimation is many a times not readily available. With urinary albumin excretion, even if we write albumin creatinine ratio, most of the labs generally perform protein creatinine ratio rather than doing albumin creatinine ratio.
They
So
are
that is a
somewhat similar, but not identical.
Identical, exactly.
If ACR is not available, then you can run with this protein creatine ratio also.
So there are two questions in the chat box. Dr. Ninad Bhandari is asking, is albumin excretion rate measured as milligram per day or so many milligram per liter of urine?
The method varies from lab to lab. And most important point related to this test is that it's a pretty cumbersome. Even if your can is not without or with any proper preservative, your reports are going to go haywire. I will not recommend albumin excretion rate at all. The gold standard for checking albumin urea is ACR now. Spot sample any time of the day.
Another question we have from another attendee is, one of my patient was recently diagnosed with type 2 diabetes and he had right nephrectomy done due to renal cell carcinoma. How frequently I should investigate him and what investigation should be done?
Right now, you diagnose him as a type 2 diabetes. He's already in the definition of CKD because of one kidney has been chopped off. So immediately check his GFR as well as ACR. And if it is normal, then if metabolic control is good, then every 6 months.
Thank you so much, sir, for the wonderful presentation. It was completely entertaining and educative at the same time.
Thank you so much.
I request Piyush to flash the e-memento for Atul, sir, as a token of appreciation. Thank you so much, sir, for your education.
Thank you so much.
So now I request our moderator, Dr. Sameer Chaubey, to start off with the question and answers.
I think we'll take the question and answer during the panel.
Yeah, I think that is better.
Okay.
You can hand over to Manish.
So now I hand over the mic to Dr. Amit Pasadi, sir, for further proceedings.
So I will be introducing Mukesh, sir. It's It's my honor again to introduce Mukesh, nephrologist at Jupiter Hospital, Thane, and also at Kimaya Kidney Care Center, Thane. He is also a consultant nephrologist at Navnath Healthcare, Hiramongi Navneet Hospital, Nephrons Hospital in Mulund. He has many achievements to his credit. He has participated as a team member in Maharashtra, Thane district's first cadaver kidney transplant, India's first domino kidney transplant. He has established a series of dialysis centers across the country with Navnath Healthcare with the aim of creating affordable dialysis for all and to ensure the quality dialysis. Now I invite with pleasure Dr. Mukesh Sekte sir to deliver his talk on salt and hypertension through a new lens. Over to you, Mukesh sir.
Thank you, Manish, for those remarks. Now I'll just so I hope the slides are visible.
Yeah.
Okay.
Yes, sir.
So in next maybe 25 to 30 minutes, I am going to throw a light on, as it appears a very simple heading like salt and hypertension, but I'm going to present in a totally through new lens, and I'm sure at the end you'll appreciate that why this topic has been a very important topic for all of us. So we all know the famous dialogue from Sholay, तेरा क्या होगा कालिया, सरदार मैंने तुम्हारा नमक खाया है तो अब बीपी की गोलियां खा. So everyone knows that the salt and hypertension is correlating. But as a clinician, I always had certain questions in my mind that yes, excess salt leads to hypertension, and there is no doubt about that. But astonishingly, a very striking factor which I came across was that how low salt increased the risk of hypertension. Yes, it's a rightly typed statement. Low salt increases the risk of hypertension, and I'm going to throw some light on it. Why high salt intake is not universally associated with hypertension. We often see two groups of people. One, we call it as salt sensitive, and the one we call it as salt insensitive. So what is the difference in their biography? Which type of the salt is more healthy? Because that is actually a layman's question, that what type of salt is very healthy, and what should be the advice to a patient about salt intake. So these are some of the questions which were bothering me, and I did some research on this topic, and I'm going to present a similar thing to you. So whenever a case of hypertension comes, we naturally write low salt intake, but without much realizing the concept of what is low salt intake. And in fact, there is still unsettled science of salt. A lack of conclusive evidence leads to disagreements among scientists over what constitutes threatening sodium levels in the diet. So we all know sodium is an important ion. It is the basic ion for a variety of physiological functions. When you say sodium chloride, the actual sodium of sodium chloride is 40%. That means if you have 1 gram of salt, around 400 milligram would be the pure sodium. 75% of that we actually get it from processed foods, 15% from cooking and the salt shaker, and 10% which is naturally contained in foods. But the dilemma is that there are still two groups. One group believes, which was a study conducted in America, that yes, they are on very high salt diet and that should be curtailed down. But the another group argues that no, most Americans are eating a healthy amount of salt and that lowering probably could be more hazardous. So this antagonistic view, which is actually the stimulation for this entire process of research, that what is actually the right entity. So we all know that actually body needs only 180 to 500 milligram of salt. And maybe the upper limit recommended is around 1500 milligram, that I'm talking about sodium. The tolerable intake should be 23 milligram, and the upper limit need not be exceeding 3436 milligram. So this is a pure sodium. Now, if you have to equate it to salt, the 1/4 tablespoon of salt is around 575 milligram, and the 1 complete tablespoon of salt, which we roughly call it as 5 gram of salt, and 40% is sodium, that is 23 milligram. That's how we all must be coming across this concept that one ideally should not take more than 1 chammach of salt in your diet, which equivalent equivalent amount is around 23 milligram of sodium, and one should not exceed any salt intake beyond 23 milligram of sodium. So that's the usual recommendation even in US. Now let's talk about sodium in health. So naturally we need salt. We cannot really get away without salt because it has a lot of functions to be performed. One, it regulates the acid-base balance in association with chloride and bicarbonate ions, as it is a constituent of buffer. It maintains the osmotic pressure and fluid balance. It is essential for muscle and nerve irritability. We all know that the action potential needs sodium flux. Involved in cell membrane permeability. It is involved in certain micronutrient metabolism like glucose, galactose, and amino acid. And it is important that it maintains the action potential even at the heart or heartbeat. So it's a very, very important ion for the body. Now let's come to the first hypothesis, that high salt intake leads to hypertension. Is there any confusion? Certainly not. Everyone would agree that yes, high salt intake leads to hypertension. And why that is so? That whenever you are on high salt diet, certain pathways get activated, but certain pathway gets attenuated. The activation is as soon as you take more salt, your ACE is stimulated, that causes the RAS axis stimulation. Aldosterone is secreted, that will result into more sodium retention, reactive oxygen species, inflammation, kidney injury. But at the other end, it also has a protective mechanism, that is ACE2, but that pathway, because of high salt intake, gets attenuated. ACE2 was more beneficial because that converts angiotensin into angiotensin 1 through 7. That stimulates this receptor called MAS receptor. They are G proteins, and which in turn result into vasodilatation, decreased systolic blood pressure, and tendency to lower BP or hypertension. But because this pathway gets attenuated and the renin angiotensin axis gets activated, you have more unopposed vasoconstriction, less of vasodilatation, so naturally it will tilt towards hypertension. So that's the mechanism by which a high salt diet can induce hypertension. So this is the same, that when you have high salt intake, there is high blood pressure, increase after and preload, there is hypertrophy which is induced, that again is contributed by the RAS players, including the aldosterone and TGF beta upgradation and fibrosis. So end organ damage and hypertension, including whether it is a fibrosis of the myocardium or it could be even fibrosis of the glomeruli. This is basically induced by high dietary salt intake, and one of the methodology by which it induces this damage is inducing hypertension. So high sodium intake is very well known with its association with variety of disorders, not just hypertension. You'll find that high sodium intake causes more proteinuria. It blunts the response of ACE inhibitors and ARBs. So on one hand, you are trying to control their blood pressure by ACE inhibitors or ARBs, but they're actually, you are getting a blunted response because they're already on high sodium intake. It causes endothelial damage by upgrading certain factors which are pro-inflammatory or leading to oxidative stress. It promotes calciuria. High sodium induces more calciuria, more renal stone, and osteoporosis. High salt intake causes hyperchloremic acidosis, and as you all know that acidosis further worsens the osteoporosis. It is a new risk factor for gastric cancer. It has been found out that those who are on high salt intake, they are prone for more gastric cancer. Even obesity is now linked to more salt intake because your thirst and appetite centers are adjacent to hypothalamus. And when you drink more salty entity, your concomitant stimulation of the appetite center also occurs, and that causes metabolic syndrome or obesity. So in short, sodium more than required is hazardous, and one of the presentation is hypertension, but it can lead to variety of these disorders. Now, whenever you are examining a patient in your OPD and you say, oh, you should cut down your salt, the usual reflexly answer by the patient is, oh no, I don't take more salt. So how to really solve this dilemma? So that could be solved by actually checking urinary sodium, and that's an ideal tool for confirming how much must be the patient's salt intake, because ideally it should not be more than 20 milligrams per liter in spot and 40 to 220 milligrams per liter per day. Of course, there are situations where there could be more sodium excretion in the urine, like high urinary sodium diet, renal disease, hypernatremia, salt-losing nephropathy, polycystic kidney disease, chronic tubulointerstitial disease, renal tuberculosis, SIDH, and cerebral salt wasting syndrome. But if none of these disorders are existing and you often see a high urinary sodium, then you can easily say that patient is on high salt diet. Even if it's denying, that confirms that he is on high salt diet. And there's a linear curve that if you are having more sodium excretion in the urine, you can certainly draw a conclusion that he is on high salt or water intake, and that also correlates with high blood pressure. That means you are on high salt intake, high urinary sodium, and you also have hypertension. So that equation between the systolic blood pressure and urinary sodium excretion is already established. And that holds true even ethnicity wise, that Eskimos are on lowest salt intake, and that's why we don't see much blood pressure in them, and Japanese who have very high salt intake, and you always see more sodium related hypertension in them, and so also urinary sodium being higher in them. So far high salt intake associated with hypertension and its linear relation is well established, and we probably don't doubt this, that you take more salt, you'll have hypertension, you'll also excrete more sodium in the urine, and urinary sodium could be a marker of high salt intake, and hypertension is at its core because of this phenomenon. Now, high salt intake leads to hypertension. If that is so clear, why it's not universally observed? That is the dilemma that we do often see clinically patients who say that is, I am taking liberal salt, but my blood pressure never goes up beyond 120/80. And often their salt intake could be as high as even 14 grams or 20 grams. So there is more light to be thrown that what is the exact relation with salt and hypertension. And this was the prevalence study of hypertension country-wise. And we found that, yes, India is heading to become a capital of hypertension. So also Germany, Finland, and overall their salt intake has been moderate to higher. And we know that, yes, there could be a correlation here between hypertension and salt. And then they actually saw that is this phenomena region-wise also seen in India. So North Indians were consuming 15 grams of salt, South Indians were 9.8, East Indians were 10, and maybe West-wide 9.38. But we did not see hypertension in the similar manner. The North Indian, though had a 15 gram of salt intake as an average, had the least incidence of hypertension. And the South people who were taking 9 grams of salt were having highest incidence of hypertension. So this was the script study which was throwing light on the ethnicity, hypertension, and its relation, religion, and region-wise. And this was an observation that the average blood pressure in North Indian is 133/81, though they are consuming 15 grams. But in South India, it is 141/88 when they are consuming less salt. So that proves the hypothesis that though high salt intake is equal to hypertension is a general understanding, it need not be universal. And now we come to an extreme end that, okay, we have agreed that high salt intake leads to hypertension. In some of them, high salt intake may not lead to hypertension. And what is the reason for that, we'll soon see. But what about low salt intake? Low salt intake has to be always beneficial, and that should always keep the BP normal. That was always the age-old understanding. But this statement should be taken with a pinch of salt. And why, that would just see. In fact, now the recent correlation between the salt intake and hypertension is no longer found as linear. It's found as U-shaped. That means if you are consuming 4 grams of salt, that is, you are at the nadir of this curve and your blood pressure is more or less normal. As you take more salt, you become hypertensive. But as you take less salt, you are again becoming hypertensive. So low salt is associated with hypertension, and this was something which probably wasn't clear, and that's how there could be more research needed, and that hypothesis is now proved that why there must be low salt intake with hypertension. So when you are on low salt intake, there is a stimulus to brain, and that causes more angiotensin 2 release and AT1 receptor expression. There is also reflex improvement in the sympathetic nervous system outflow, which will result to more salty appetite, more thirst, and the sodium water retention, and they will try to correct this low salt intake into normal sodium. That means though you are forced to do or take less salt, the body will not allow that. The body will counter-regulate and try to achieve normal sodium, because body realizes that no, salt is necessary. Even if he's consuming less salt, let him force to eat more salt and increase his salty appetite or thirst. And at the other end, this low salt intake, by increasing the sympathetic nervous system outflow, improves the renal sympathetic nerve activation at the efferent level. RAS is activated. There is more sodium and water retention, increased renal nerve activity, renin release, and ultimately leading to hypertension. At the other end, if you are chronically consuming low salt, you'll have a blunted cardiopulmonary baroreceptor responsiveness, and that will again add to hypertension, because one of the protective phenomena of baroreceptor response is gone, and unopposed vasoconstriction continues, and that results into hypertension. So when you're on chronic low salt intake, even that becomes a risk factor for hypertension. Now, hypertension scenario in India is that we all know 20 to 40% patients in urban are hypertensive, 12 to 17% in rural are hypertensive. There are 2 cases of undiagnosed hypertension for every diagnosed case of hypertension, approximately 67% unaware of hypertensive status, and there is a considerable gap in detection and control of hypertension. And just 1 out of 7 is actually the case where there is a proper control. The other 6 are either under control or not controlled. And the overall percentage is the control population is 58%, but the uncontrolled population is nearly 42%. And the worrisome factor is, as our old thinking was that the hypertension is disease of old that comes after 60. This picture will tell you that 2/3 of the total hypertensive population are in fact younger. And they are not only hypertensive, 80% of them have some or the other additional comorbidities, either obesity, glucose intolerance, hyperinsulinemia, reduced HDLC, elevated LDLC, elevated triglycerides, and LVH. And more than 50% have not 1 but 2 or more comorbidities. That's how it is certainly a worrisome factor. We all know about syndrome X. One of the players of syndrome X is high blood pressure, apart from obesity, high blood cholesterol, and insulin. And it is basically a programmable approach where fetal malnutrition and rapid post-independence urbanization with genetic susceptibility or thrifty genes, they result into your epigenetic changes in such a way that after birth, at 2 weeks, you actually establish insulin resistance. 2 months, you have elevated triglycerides. 6 months, you can have obesity visible. 12 months, you have high blood pressure visible. So that is, of course, is the epigenetics. Any genetic epigenetic disorder comes into the action when there is environmental influence. That means you're carrying these genes. Now you become obese, or you don't control diet, or you're on a high salt diet. Naturally, blood pressure would be a very prominent phenomena. If you can control these external factors or the environmental influences, maybe you'll get away by either controlling this disease for a fairly long period of time, or you might even escape getting those disorders. So that's the concept of a genetic predisposition, but you have to have an add-on environmental influence. So what's the evolution of salt with human race? And that's a very, very interesting phenomena. And you'll find that Paleolithic era, that means 2.4 million years ago, the average consumption of sodium that time was just 768 milligram. And now if you can imagine, over a period of many years, 2.4 million years, as the evolution has occurred, but your renal physiological system is not all that altered over a period of 5 years. So that is a point which we'll make. And in fact, salt being so minimally required became a very, very important commodity. Right up to the 20th century, the pound bars of salt, called as amol, was the currency in Abyssinia, that is Ethiopia. The salary word has come from salt. That means you're actually paying off someone by giving salt, and that was your salary. Salary d'Uyuni is a salt flat in Bolivia, and that is considered to be an 11-kilometer long belt of salt, and it is a very prestigious and very, very, very precious entity for them, that is Bolivia. So salt was always considered as a very important entity for the body, but at the same time, it could be poisonous. In China, this was used to, in fact, commit suicide. Even infants, if accidentally given salt, would die, and users don't require more than few pinches for an infant to die if they are given salt. And there was one tragedy where rather milk formula, salt formula was given accidentally, and there was a series of death in that population. So it could be a poison. It's a commodity, but it is a poison. We had Dandi March of Mahatma Gandhi, and then our entire approach towards salt changed. No, we started using salt left, right, and center. The average salt consumption easily, went up to more than 2.5 gram in no time. And now, so we in fact proudly say that even hamare toothpaste pe bhi namak hai. No, so that is the addiction which we have. We are now sprinkling salt on almost everything, and your average consumption from 768 milligram went up to nearly 15 gram. But what is the physiological adaptation? That's most important. You kept having salt load in your body. How many are the mechanisms in our body which will easily excrete salt because you're consuming in excess by physiology? So what can lead to salt load? Diet, brain endogenous OABN. the sympathetic nervous system, angiotensin 2, RAS, aldosterone, and ADH insufficiency. All of them are there to increase salt in your body. What can excrete? Only ANP, atrial natriuretic peptide, BNP and CNP. That means those natriuretic peptides. Diuretics, which are not natural, they are exogenous, they are consumed. And one mechanism by which you excrete salt called as pressure natriuresis, which is nothing but a glomerular adaptation to your increased salt intake, so that hyperfiltration results into more salt loss. So you have natural factors only as natriuretic peptides. There is no other natural factor to excrete salt. And there are 10 players to add salt into your body. So what is the pressure natriuresis curve? That as your salt intake goes up from 2 gram to 4 gram to 6 gram, your arterial pressure keeps increasing. The whole idea of increasing arterial pressure is to transmit this pressure into glomeruli so that there is intraglomerular hypertension that pushes the salt out and tries to balance your salt intake equal to salt excretion. But at the cost of what? At the cost of glomerular hypertension. That was called as pressure natriuresis curve. So this is your glomeruli. You intake more salt, automatically your intraglomerular pressure will go up, and that will result into intraglomerular hypertension and more salt loss. Now there is something called as acute salt sensitivity of blood pressure. The salt sensitivity is a well defined by the steady state relationship between salt intake and blood pressure. So there is something called as chronic pressure natriuresis relationship or renal function curve. That means as you increase salt intake, your pressure will go up, and they will go up only in a group of individuals which are salt sensitive. So you can imagine this was the pressure 100, which slowly went up to 150 or even up to 200. But those who are not salt sensitive, they maintain their pressure as it is. And that is salt resistant. That's why we saw that in South, we had more cases of hypertension despite low sodium intake because they are salt sensitive. And in North, we probably saw less cases of hypertension despite high salt intake because they are salt resistant. And this is again genetically derived, that would you fall into a group of salt sensitivity or salt resistant. So naturally in your clinical practice, you'll see both the type of patient. Some consume little more salt and next day they are edematous, they are hypertensive. Your 2 antihypertensives look like insufficient and you are forced to add third one. And nothing else has gone wrong except that they were salt sensitive and they consume more salt. As against that, there are another group of patients who probably cherish very salt intake, but their BP remains stable. And that was one of the hypotheses I put forward, that salt intake in everyone need not be equal to hypertension. This is mainly a phenomena seen with salt sensitive patients. And in fact, the peculiar BP observation in them is that first, in all this salt sensitive hypertension patient, the night dipping of BP will go away. So they will become non-dipper. So when you are on ambulatory BP monitoring, you will find all these patients having non-dipper like a presentation. And that will in fact be the early method that, oh yes, they have pressure natriuresis phenomena. And that is the reason at night, their BP is not dropping because they are themselves increase their intraglomerular pressure in such a way that they want to excrete all that extra salt which they consume in the day. And that's why at night, the glomeruli are hyperactive, they are hypertensive, trying to push out salt at the cost of non-dipping of the pressure. So that's the early finding that their pressure natriuresis is at a problem. So in fact, this chart tells you that in case you are salt sensitive and you increase more salt, you have to achieve more salt removal so that your salt intake should be equal to output. But in a way, they are having insufficient pressure natriuresis. They try to achieve that, but yet their salt retention is more. And while achieving that, when they are having increased cardiac output, increased blood pressure, increased autoregulation alteration, they are starting phenomena which then become slowly permanent. And their chronic pressure hypernatriuresis results into a permanent change in their total peripheral resistance, and there is a sustainment of high blood pressure. That's why we now say that the essential hypertension could also be because of abnormal pressure natriuresis. And those who are not salt sensitive, you'll find that no matter whatever may be their sodium intake, the sodium output and intake remains the same. with no change in their blood volume, blood pressure, no change in their BP. So that's actually a genetically programmed entity, whether you have an abnormal pressure natriuresis or you have a normal pressure natriuresis. So now the genesis of essential hypertension could be stated as a defective natriuresis, increased renal availability for sodium. They also could have other comorbid factors like obesity, insulin resistance, RAS activation, sympathetic nervous system activation, hyperaldosteronism, some tubular channelopathies, so that their handling of sodium is improper. And finally, the Guyton's hypothesis that there is less natriuresis in all of them with a relative net retention of sodium, volume expansion, and hypertension. So that's the actual newer theory coming up even for essential hypertension. That's why previously hypertension was considered as cardiology phenomena. Everyone thought it is hypersympathetic tone and peripheral vascular resistance being high and something related to heart. And now slowly this concept has been renal. In fact, even essential hypertension is now being classified based on the renin, the low renin, normal renin, and high renin hypertension. Renin being a renal hormone. Slowly we now know that essential hypertension is nothing but an altered phenomena in the kidneys where there is defective natriuresis, and that is the main essential factor which over a period of time the population could get this disorder because of the altered habits of sodium intake from 768 milligram upper Paleolithic area to nearly 15 grams now, and that has been the major culprit. And in fact, this has been proved that the mineralocorticoid receptor activation in the kidney, which facilitates distal sodium reabsorption through epithelial sodium channel activation, causes salt-sensitive hypertension. So now we exactly know what must be the cellular change to label them as salt-sensitive hypertension. Second, a renospecific sympathoactivation may cause an increase in BP under conditions of salt excess. Renal beta-2 adrenoreceptor stimulation in the whole kidney leads to decreased transcription of the gene called WNK4, and this negative regulator of sodium reabsorption results into distal convoluted tubules resulting into salt-dependent hypertension. So all these theories are coming up that ultimately hypertension is nothing but a genomic variation. There's a gene variant associated with salt-sensitive phenomena, gene variant associated with response to antihypertensive therapy in salt-sensitive pressure. Those channels like NEDD42, SNPS, and NEDD42 alteration or a genic handling of sodium across the channels. And in fact, those various channelopathies are also getting programmed, that sodium hydrogen antiport, sodium glucose symport, sodium ion channels. Everywhere sodium is a common player, but in proximal convoluted tubule or in thick ascending limb or in distal convoluted tubule or collecting duct, everywhere those channels are active, and those channelopathies ultimately suggest or confirm whether the patient is likely to be salt sensitive or not, and whether he'll get an abnormal natriuresis or not, or whether he will get salt related hypertension or not. And this is all genetically programmed but triggered by an environmental influence, and that is your net salt intake. So clinical studies have been done in this, and this was a test where they in fact gave patient a low salt diet and observed their blood pressure, and there was an effect of longer term modest salt reduction in blood pressure. And this is a Cochrane systemic review which proves the point that if you bring down your salt intake from 9 to 12 gram to 5 to 6 gram, you have a modest benefit. But if you can further reduce it to 3 gram per day, this will certainly help. This is again helping in those populations which are salt sensitive hypertension. So the last aspect of this is there's a treatment of hypertension, and where we have to now consider on what should be your salt diet or lifestyle modification. Now, salt is such a question by a layman that which salt is good. They will say sea salt, kosher salt, Himalayan salt, or kala namak, or black lava salt. So there are various salts which are available. Generally, when you compare with table salt and sea salt contains over 84 minerals. There is no high blood pressure observed with sea salt. Table salt contains only sodium and chloride. Sea salt has 85% sodium chloride and 15% of other trace elements like selenium, iodine, boron. There are no trace elements in table salt. It helps balances the pH, the sea salt, while table salt is heated up to 1200 degree Fahrenheit and contains additives. And sea salt also has an antibacterial and helps in mucus and muscle cramps, while there are no such benefits observed in table salt. So in short, table salt is a processed salt, has only sodium chloride. All other salts are actually mixture of sodium chloride with other minerals, which could be important to body or they might play a beneficial role. But what is more important is every salt more or less has same sodium content. When I'm saying 1 gram of salt, that means 40% is the sodium. So roughly in 1 gram you have 40 milligram or 400 milligram. In 1 gram 400 milligram of sodium. That is 40%. Now if I take black salt, the sodium content is 36.8%, not something very different. Senda namak has 38.7 sodium, not very different. If I compare with Himalayan salt, yes, Himalayan salt is something which has the lowest sodium content, but otherwise not very different for the Senda namak or Kala namak. So when you consider table salt, which might have 23 milligram of sodium in 1 tablespoon, there are about 2000 milligram of sodium per tablespoon in sea salt and 1700 milligram of sodium in Himalayan salt. Now what happens is if I taking 1 tablespoon of Himalayan salt, I get less sodium, but less taste as salty, and that's why the person would put 2 tablespoons to get the similar taste, and they are under the impression that, oh, Himalayan salt is safe, we can use as many tablespoons as you can, and that's wrong, because all other types of salt though has a lesser sodium in that volume of 1 crystal in the tablespoon, if you are using it for higher amount, it will carry the same sodium content, and except Himalayan salt, all other salt, the sodium content is almost matching with table salt. So if patient is emphasizing that, no, we to eat Senda namak, we to eat Kala namak, it is equally dangerous. Okay, and that is a point which one should emphasize on. And that's how this concept came, that one chammach kam. This was actually the slogan of WHO. And if you consider 1 chammach kam also, you are likely to reduce your 5 gram of salt, which is from your diet. So if you're consuming 10 grams, it will come down to 5 gram, 15 gram will come down to 10 gram, and even that will give a lot of benefit. DASH diet, everyone knows that was basically the diet to stop hypertension, and that again was mainly made up of either the legumes or lentils or basically fruits, and they had almost no traces of salt in them, and one could observe that the blood pressure is in fact minimizing, and they could match with that standard 23 milligram per day or sometimes even 1500 milligram per day with this diet. So in fact this diet could go a boon for all salt sensitive hypertension. We are on a high salt diet. Now, if I resort to lifestyle modification, what is its impact on systolic blood pressure? Physical activity can reduce your blood pressure by 4 to 9, DASH diet 8 to 14, dietary sodium restriction 2 to 8, alcohol consumption if it is moderate 2 to 4, weight loss almost 5 to 20, stress reduction maybe 5 millimeters, tobacco cessation 2 to 4. So almost 8 is the unit of blood pressure you can reduce if you resort to dietary sodium restriction, and that's a very important correction. Probably the one single tablet of BP could go away if they just resort to dietary sodium restriction. It's a very important entity. Now, what's important entity is that many often these metabolic syndromes who have obesity and hypertension are given the advice that yes, they should cut down on carbohydrate. What is this relation of carbohydrate with hypertension? So when you're on high carb diet, you naturally have high insulin. Like Dr. Atul just spoke about the patients of NIDDM, and these NIDDM are nothing but all insulin resistance patients who already have a very high amount of insulin. What insulin does is it's a direct hormone causing avid sodium absorption from the proximal tubule. More the insulin, more would be the sodium absorption from the proximal tubule. That means it is as good as that your high carbohydrate is equal to 10 grams of salt, even if there is no salt. Why? By virtue of just hyperinsulinemia. And as soon as you go on to low carbohydrate diet, your insulin levels are reduced, your sodium absorption goes down, sodium excretion goes up, and that's how your blood pressure is controlled. So I used to always wonder that our patients have twin abnormalities, that they are hypertensive also and they are diabetic also. And many times diabetes starts first. They say, oh, diabetes started in 2002 and blood pressure is 5 years old. Maybe this is happening not as a part of metabolic syndrome. It's just because of hyperinsulinemia, because your hyperinsulinemia will keep absorbing sodium from the proximal tubule. One fine day, they'll become salt-sensitive hypertension, or they already have a genetic predisposition as salt-sensitive hypertension. They will start having hypertension after a couple of years of diabetes. And that's how the low carbohydrate diet certainly would go a long way here, and that will control your sodium excretion also and the blood pressure also. So the key message is salt restriction is recommended, but for whom? Only those who have high blood pressure, diabetes and kidney disease, where you know that they are prone for a lot of sodium retention. they are 50 or older, or they are having genetic preponderance for salt sensitive hypertension like African Americans or even Indians for that matter, because we see a very high amount of salt sensitive hypertension in India. Those who are proteinuric, those who are prone for stone disease, those who are obese, or those who have osteoporosis. That is the group where you certainly emphasize that they should be on salt restriction. That will go a long way of correcting all these abnormalities. Urinary sodium may help in determining the salt intake. However, lean and thin, normotensive, no comorbidities can continue their usual salt intake, as reduction in salt below normal would give rise to hypertension. So you have to identify your patient. Those who are very lean and thin, often we say, oh, you know, so what is the general idea by which I can keep my health maintained? And you say, oh, you cut down your salt, cut down your carbohydrates. No, here cut down on salt could be hazardous. If it's normotensive, do not bother about salt intake, because probably he's not salt sensitive hypertension. He might be consuming 15 grams of salt. His body is such that his intake of salt is equal to output of salt without leading to hypertension. So that low sodium intake could be hazardous, could be an inducer of hypertension. This entity one should keep in mind and should not be randomly explained to everyone that, oh, cut down salt. But that other group, the other cohort which you already seen here, naturally needs salt restriction. So that's an important message we wanted to give. And thank you for your patient hearing, and we'll be open for all questions.
Thank you, sir, for that excellent presentation. There are few questions from the our listeners. The first one is from Prajakta. She is asking, what is the effect of long-term use of RO water filters on kidneys?
Yeah, so the RO water, of course, one is it's antibacterial type of water. In fact, there is more emphasis now on alkali water. And this alkaline water has been found to be effective in patients who have more renal related acidosis or acidosis related dyselectrolytemia, or even hypertension is now considered to be in the acidic milieu. So that's how, as a tissue preservative, alkaline water has been given a lot of emphasis, because your body is preserved well at the alkaline pH rather than an acidic pH. And of course, the pH just tweaks by few points rather than 7.33 to 7.44. By your alkaline water, it goes to something like 7.45 or 7.5. And that alkaline pH is supposed to be very effective. RO water, yes, would help you just as disinfectant.
Sir, another question is there any relation for people living near coastal areas and hypertension?
Yes, very much, because we find that those who are in coastal areas are very prone for eating fish, and that is from salt water. And even if those who consume fish 2 or 3 times in a week are unknowingly increasing their salt intake by many fold. And all the coastal people have basically been prone for salt sensitive hypertension if their genetics predisposed for that. Plus, they are usually very prone for stone disease. In fact, in Andhra, there are areas where the coastal areas like associated with Godavari River, they have huge incidence of stone disease and hypertension is mainly because of their diet and salty fish intake.
Sir, another question is Himalayan salt better than the regular salt? I think you have already answered that question.
So I do agree that that is the best salt to have. Unfortunately, it's not easily available. But those who have connection with Uttarakhand, they can easily avail this pink Himalayan salt, and that has the least sodium intake, and all other trace elements which are there are very beneficial to the body.
Last question is there any correlation of salt sensitivity with menopause? Would you like to answer that question, sir?
Salt sensitivity with?
Menopause in females.
Yeah, so even post-menopausal people are prone for hypertension. One, of course, because of the reduction in estrogen, then they are more prone for osteoporosis, and again hypertension. So if post-menopausal people start depleting their salt intake, especially those who are salt sensitive or obese, then it would certainly help in preventing their establishment of essential hypertension, or at least will postpone the need for therapy in essential hypertension. So that goes well in post-menopausal period.
Thank you so much, sir, for an amazing and informative talk that has brought us to light to a lot of many myths and many certain confusions that people had in their minds regarding salt and hypertension. I'm pretty sure all our participants and all the viewers must be much more informated after this talk. I request Piyush to please flash the e-memento. We thank you, Mukesh sir, for a very informative and a beautiful presentation over salt and hypertension. Thank you so much, sir. I now hand over the virtual mic to our moderator, Dr. Sameer Chaubey, for the panel discussion. I request all panelists, Dr. Atul Ingle sir, Dr. Mukesh Shetty sir, Dr. Manish Balwani sir, Dr. Amit Pasari sir, to join our moderator in the panel discussion.
So after these two very nicely presented and informative talks, we come to the last but very interesting interactive session of panel discussion. And since we are short of time, I request the participants to put questions in the question answer box or the chat box. And I would be taking about 2 to 3 questions per panelist, because more than that, I don't think would be possible in this short period of time. I would first start the ball rolling by asking Atul. Atul, in your viewpoint, which is the best molecule to give if you are facing people with recurrent hypoglycemia?
Recurrent hypoglycemia is a characteristic of diabetic nephropathy. As insulin excretion is reduced. And if you are using oral hypoglycemic agents, it is further fueled, or there is a further deterioration because pharmacokinetics and dynamics changes totally. The best molecule to treat hyperglycemia or hypoglycemia of a diabetic nephropathy is insulin. Because if you look at the meta-analysis or all the trials, the proper glycemic control, or what they call it as a near euglycemia, can be achieved only with the insulin, and that too the newer ones, analog insulin.
And what is your take on these newer insulins of once a week and once in 15 days and once a month?
They have been tried in phase 3 clinical trial and yet to come to the market. The time will prove what is the utility, because the longevity is all but kind of a pharmacokinetics once you inject. Because if you look at the basic insulins or even analog insulins, is a hexamer or polymer molecules. Once injected in subcutaneous plane, they disintegrate slowly, and that is how they provide an insulin effect over the period of somewhere around 22 hours to 36 hours. So same kind of method has been adopted for using this once a week insulin. But utility wise, we'll come to know only when we use it practically. Very difficult to comment anything right now.
Okay, thank you so much. Mukesh, a couple of questions for you.
Yeah.
When we are talking about salt sensitivity causing hypertension, so we come across a lot of salt cheaters. Like you said, "मैं तो नमक खाता ही नहीं, मेरे पास तो खाने का होता नहीं." Would you recommend a ABPM regularly in such patients to see BP spikes during lunch, dinner, or meal time?
Yes, one of course is ABPM. In fact, that will immediately pick up those night dippers, because these are the patients who actually don't dip their blood pressure at night. But a second, which I emphasize upon, is the urinary sodium excretion. Not a very difficult test, can be done in spot urine. We know the range is 20 to 200. If urinary sodium spot sample goes 600, then we know that he's on such a high amount of sodium intake. So even if he denies, at least we know that he's on very high salt diet, and one can counsel that way. So urinary sodium and ABPM, both are important.
Well, then we can correlate with the two results.
Yeah. Correct.
Secondly, you spoke about salt and proteinuria. Many people would be having this question as to, is the high blood pressure causing glomerular hypertension and proteinuria, or salt acting in another way to produce protein in the urine?
So both the mechanisms are there, that when you have intraglomerular hypertension, that it's also transmitted on the podocytes, and that causes some degree of early podocytopathy. So, and intraglomerular hypertension being triggered by sodium. But by other channelopathies, that whenever you have more sodium in the intratubular space, that has the direct effect as ionic flux of proteins into the tubule. And that is why more the sodium in the urine, there are high chances that more sodium would be leaked out from the capillary space into the tubular space, just because of the presence of sodium ion into the tubule, and if it is high in the quantity. So both electronic gated proteinuria is also triggered by sodium, and intraglomerular hypertension related podocytopathy is also the mechanism. That's why overall, if you want to minimize proteinuria, then the sodium should be avoided.
There's a question in the question box which says that in these days of COVID, everybody is doing salt gargles. So is it causing a rise in BP?
No, not much. There is a very trace amount of salt which would be absorbed. If it's a gargle, that means your 90% of it is throwing out. So that probably should not be the responsible factor for hypertension.
True. Now coming to Amit. Amit, can you hear me?
Yes, sir.
Can you provide some details on when not to use the SGLT2 inhibitors?
Sir, as we know, SGLT2 inhibitors now form an integral part of management of diabetic patients, especially at high risk for CKD progression. But SGLT2 inhibitors have not been validated in, tested extensively in patients with type 1 diabetes. Patient with diabetic ketoacidosis or who has high chances of having ketosis should preferably be avoided from giving SGLT2 inhibitors. And patients who have predisposition for urinary tract infection, like prostatomegaly, indwelling catheter, or abnormalities, anatomical abnormalities of the urinary tract, they should probably be, we shouldn't be using SGLT2 inhibitors in these patients.
Okay. Thank you. Manish, would you like to answer this? When to suspect non-diabetic renal disease in a diabetic patient?
Yes, sir. Especially in diabetics, we have to look for the duration of diabetics. If duration is less, for example, it is less than 5 years, and there is sudden onset of renal dysfunction, sudden onset of severe proteinuria, sudden appearance of pedal edema. Also, if fundus is not showing any changes of diabetic nephropathy, if there is gross hematuria or macroscopic hematuria, then also if there is systemic evidence of systemic illness like vasculitis, SLE, then we should suspect non-diabetic renal disease in diabetic patients, as treating the underlying illness can definitely help in these patients rather than only controlling the blood sugar levels.
Okay. Another question, Manish, is if somebody has renal failure, do we always have to give insulin, or we can go about giving oral OHAs?
Certainly, sir, we can use few of the OHAs. It depends on the eGFR. We have to look at the glomerular filtration rate. So even nowadays, metformin is used up to the eGFR of 30. More than 30, we can use it. Earlier, it was said that we can use it up to the 45. But we have to be careful for lactic acidosis. We can use linagliptin, teneligliptin, repaglinide, in some cases, pioglitazone. Gliclazide can be used as it is short-acting. Glimepiride can be used, but we have to reduce the dose and look for the eGFR and accordingly adjust the doses of these medicines.
Amit, when would you like to see for secondary causes of hypertension in a patient of uncontrolled or resistant hypertension?
Sir, a patient presenting below 30 years of age, a non-obese person presenting below 30 years of age with hypertension, or first presentation with malignant hypertension, when there is associated metabolic abnormalities like presence of hypokalemia or metabolic alkalosis. And if previously properly controlled hypertension suddenly becomes difficult to control, or the number of drug requirement goes high, then probably we should be looking for secondary causes of hypertension.
Okay. Atul, one for you. What factor would you like to give importance? Time in range or time above range?
Time in range. Because if you look at the various studies and the observation period, where observation period was 10 years, if at least 50 to 60% of time in a 24 hours spent in the range that is 70 to 180 milligram per deciliter, that is what we call it as a time in range, that would be beneficial to the patient. Time below range is given importance because of hypoglycemic episodes. See, hypoglycemia and hyperglycemia excursions has shown to have very high mortality related to it. Even though your HbA1c may be around 7 or 7.5, but if there is a lot of excursion, what we call it as a high glycemic variability, then mortality would be very, very high. So time in range is more proper. I think once in a while, at least once in a year or once in a 6 months, one should go for a continuous glucose monitoring, and even 7 or 8 days data will give you enough idea about this time in range.
Okay. Thank you. Mukesh, you have a lot of questions coming in for you. One is, what should be the salt intake in renal transplant patients?
So again, renal transplant patient also, it should be as low as possible because they already have old kidneys. They are not removed. So they would be hypertensive. They would be requiring antihypertensive therapy. Lesser the salt, lesser would be the need for the antihypertensive drugs. So even transplant patients should be on low salt diet.
Second question is, which antihypertensive would you choose in a newly detected hypertensive?
So now we always have this angle of anti-hypertensive with renoprotection. As I mentioned, that there is a paradigm shift of understanding genesis of hypertension, where kidney really play a major role, or even hypertension as a culprit for renal damage. So why don't we use a drug which is more renal safe or which is more renoprotective? So in that, newer calcium channel blockers, azilnidipine or efinodipine, they are better because they control blood pressure, they are anti-proteinuric, they don't lead to edema like your amlodipine, and overall, sometimes they are less efficacious, but if you increase the dose and use the right dose, then you are likely to maintain the blood pressure to your target level. So newer calcium channel blocker is certainly the promising drug, which also adds to your renal safety, and they are also anti-proteinuric.
Now this question for you and Atul both. Once we start with the newer calcium channel blockers, so do we need to give another, say, ACE inhibitor or A2RB to accentuate the effect or get a better anti-proteinuric or renoprotective effect?
Would you like to start, Mukesh, or shall I?
No, you can.
Okay. If you look at the newer guidelines published in 2021, European Society or International Society of Hypertension, they are coming out with the concept of polypill to reduce the burden. So they are recommending combination pill. And the most common combination is a calcium channel blocker plus ARB or calcium channel blocker with the diuretic. So depending upon the albumin urea, which indicates endothelial injury, then you have to go or opt for it. Mukesh, you're...
Yeah, exactly. Basically, there is a synergism that if you choose newer calcium channel blocker, they themselves have a good effect on afferent and efferent arteriole. Now you have an ACE inhibitor, which is having an additional benefit of the efferent arteriole. So when you combine the two, your intraglomerular pressure dropping vis-a-vis the proteinuria dropping is synergistic. And that's how you achieve a better renal safety rather than using a single drug. So this combination therapy is now almost the thing in your clinical practice. Plus, whenever you talk about renal hypertension, everyone knows that the average need for controlling blood pressure is more than 3 drugs. They are not like your essential hypertension where only 1 drug is sufficient. So why not we use these drugs together so that there is more synergism at the kidney level?
Perfect. One last question to you, Mukesh, is somebody is asking how much should be the daily intake of alkaline water?
So there is no limit. As we normally drink alkaline water or any water for that matter, is usually 2 to 2.5 liter in a normal renal patient. The similar amount can be consumed of alkaline water. Not every ingestion of alkaline water shifts the pH, but yes, there is a marginal benefit of sinking pH by few units, simply because if you are consuming a lot of alkaline water, body again has an autocorrective phenomena. Even if you are pushing more citrate or maybe more, phosphates or any other sort of ingredients as a mineral which is alkaline, Yet you'll have autocorrection by HIN and by chloride reflux and efflux. And that is why net pH will only shift by 0.2 or 0.3. But yes, during the consumption of that water, you have some benefits.
Okay. Now, last question for Manish. Manish, any tips on the new molecules to treat diabetic kidney disease? Manish, can you hear me?
Yes, sir. There are few studies now. In that finerenol. Yes, sir. Am I audible, sir?
Yeah.
Sir, am I audible?
Yes.
Yeah, sir. So there are new molecules like finerenone. It has been found useful in diabetic kidney disease, especially when used between the stage 2 to stage 4. So again, this is protective and has good cardiovascular outcomes. So this is a good molecule, but again has a side effect of hyperkalemia, which we have to be watchful again.
Okay. Now, Amit, one last question for you. Can you comment on if diabetic nephropathy can be reversed?
So diabetic nephropathy as such was considered to be an irreversible lesion. But one study in type 1 diabetic patients who underwent pancreatic transplantation showed that after 10 years of euglycemia, the biopsy changes were reverted. So probably a long-term euglycemia mainly in type 1 diabetic patients can probably reverse the changes of diabetic nephropathy.
Okay, thank you. Now, before I end this, I want to again go back to Atul for a last question. How frequently should we be seeing HbA1c in a follow-up of diabetic nephropathy?
Every 3 months, because it gives average of last 3 months. So
and how do you interpret whether the diabetic
see, basically HbA1c is a marker of glycemic control. Means whether you are achieving target or not. And whatever the documentation or data you keep, like fasting or postprandial or home sugar management in the form of pre and postprandial, they are meant for the adjustment of the drug dosage. So both things are very different. So ideally HbA1c should be checked every 3 months.
Okay.
And that is for the control basically.
I think I've also taken up most of the questions in the question box. I think we've exceeded time also. So I'll hand over the mic to Rahul again. Thank you so much, panelists. It was fun having you with us on this evening.
Same here. We are also
Thank you.
honored.
So now we come towards the end of this fantastic CME. Before that, I'd like to thank the chairpersons, Dr. Amit Pasari sir and Dr. Manish Balwani sir. I request Piyush to please flash the e-mementos as a token of appreciation for their time and their knowledge and the way that they have gone through with the CME. Thank you so much, Amit Pasari sir. It's been a pleasure having you on the CME today. Thank you, Manish sir, for being on board today.
It was our pleasure. We would like to thank you and thank IMA for getting us involved in this wonderful CME.
Thank you so much, sir. I thank Dr. Sanjay Devtale sir, Dr. Sachin Gathe sir, Dr. Shehnaz Chimthanwala ma'am for giving us this opportunity to have a great platform for this beautiful CME. Thank you so much, sir. Thank you so much, sir, and thank you so much, ma'am. And last but not the least, thank you so much for all those who have attended this CME. I really hope that it has been informative and eye-opening for a lot of things.
I think we now say goodbye to all panelists, finish off this CME. Bye Atul, bye Mukesh, bye Amit, bye Manish.
Bye, sir. Thank you.
Bye.
Thank you. Thank you, Atul sir.
Thank you, everyone.
Thank you, sir.
Bye bye all
Nice
of the
seeing you.
members of IMA.
I hope next CME should be in physical at
Oh
Nagpur.
yes, I will see to it that you come here.
I would love to. Even Mukesh would love to.
Oh,
Yes,
definitely. We all going to be together next.
Thank you all.
Thank you so much.
Bye bye. Bye bye.
Bye.
Thank you. Good night. Good night all.
Good night.
Good night.